is 308 milliosmoles, urine is around 616. So in about half liter, it can bring down all the osmoles, and you're left with half liter of distilled water, which is added to the blood, and your serum sodium will go on deteriorating if you do this. So that's why treat with 3% saline. Suppose your nurse tells you, your pharmacist tells you, I don't have 3% saline. So how will you treat your SID? How will you treat your SID in this patient? Give him a diuretic. If you give him a diuretic, your urine osmolarity from 616 will drop because it will get diluted, and therefore your saline will work. If you don't have 3% saline, if you can increase your strength, make the other strength less. That logic is what is applicable here. So this was excessive water drinking. Why was this so? Now the first case which we did, excessive water drinking, for those who didn't know, is this real? Yes, serum osmolarity is low, it is real, right? We saw that, it's real. Now what is the next question? How is the water excretion? If the water excretion is, you know that urine osmolarity is low, less than 150, so either this man is drinking too much water, or he's got tuberculosis, or he's malnourished, or this man is pregnant, right? So he's not pregnant, we understand that, right? People are still looking seriously at the third possibility. He's not pregnant, believe me. Is he malnourished or tuberculosis? Nothing available in the history. So reset osmostat is out. This is psychogenic polydipsia. He is a psychiatric patient. Excessive water drinking is the answer. So you understand how you approach the question to get the answer. So we finished hyponatremia. You tell me when you're tired. We will go on to the next topic. Hypokalemia. Again, extremely important electrolyte disturbance in the ICU, hypokalemia. Let's start with this audience response question. While the previous ones were all true stories, true case histories, these are all hypothetical stories. All are 28-year-old females. Okay? All have a potassium of 1.8. But I made this to bring out thing. A 28-year-old female is admitted with rapid progressive weakness of the limbs. History of similar episodes in the past. What is the most likely reason for this picture? This is the age, sex, blood pressure and heart rate. These are the plasma values, and these are the urine values if you want to use. I'll give you some time to think about it. Which of this is? Patient has come to you. What is the most likely reason for hypokalemia? Okay? Everyone can answer, even if you don't know, make a best guess. It's like multiple choice questions, no negative marking. Okay, majority of you said D, hypokalemic periodic paralysis. While you're right, I trust that you've done it on history, not on these values here. Okay, so let's go on to the next question. Again, a 28-year-old female with a potassium of 1.8, but the history is gradual onset of weakness of the limbs over a few days. Urine output is 3.5 liters per day. What is the cause of her hyponatremia? Everyone should answer. Let's see where you are. The first one was easy. Only 13, 14 people. Come on, quickly. Majority of you said renal tubular acidosis. Okay. Then some of you said diuretic use. Someone said hysterical. Okay. Many of you didn't answer. The correct answer is renal tubular acidosis. And again, I am very happy that you got it right. We will see why. We will come back to this. Now, more challenging. No history available. This is the what is the most likely reason for this hypokalemia in this patient? Since you are good, I am going to start the timer early. You are doing very well. I think you've got a good understanding of hypokalemia. Only 4 people have answered. Come on, quickly. Wow. Varied answers. Okay. Majority of you for A and then B. The correct answer is E. Mineralocorticoid. This patient incidentally had an adrenal carcinoma. Okay, but we will come and see how it is. How many got it right? Quite a few of you got it right still. E, yes. 6 of you got it right. That's good. Now, this is something again important. In the treatment of hypokalemia, how many of you have seen 2 ampules of KCl in a pint, 3 ampules of KCl in a pint? Can you just raise your hand if you've seen it? Let's be honest. If no one raising hand means you're saying, you know, the Americans are all fools and everyone is a fool. Let's be honest. I have seen 2 ampules and 3 ampules. Okay? Now I am going to show to you how it is rubbish to put 2 ampules and 3 ampules of KCl, and you will still say I am putting 3 ampules, potassium is not increasing. This is a patient who has come with severe dehydration following vomiting and contraction alkalosis. pH is 7.7, potassium is 2. Right? I am not giving any potassium to this patient. I am just treating the dehydration with 4 liters of saline. Okay? I want to know that after giving 4 liters of saline, what will be my potassium? From 2 will it become 1.6, will it remain 2, will it become 2.4, 2.9 or 3.5? Audience response starts now. There is something to learn from this case. What will happen if I don't give potassium to a patient with hypokalemia? Good, 14, 15 people have answered already. Maybe a good sign or a bad sign. Alright, very diplomatic. All parties are getting some vote. Majority of you said E, 3.5. It's wrong. It's 2.9. But at least I think by the way I was asking question, you realize it has to be different from what it appears. It will not fall further. It will actually increase. But see the beauty of this. You will see why. That you don't have the treatment of hypokalemia is giving fluids and not just giving potassium. Alright? We will see why this is so as we go through, but it's important to realize this. And then if you don't give fluids, if you give 2 ampules and 3 ampules KCl in a pint, you're giving a lot of potassium, but you're not giving volume. So what happens is, all that potassium goes in intracellularly. Your serum potassium will not rise. There's no blackboard to explain to you. What happens with alkalosis, metabolic alkalosis, is there's less of H ions outside. Alkalosis is there, less H ions. So H ions from inside the cell come out, right? And to maintain electrical neutrality, potassium has to go inside the cell. So as long as you've got metabolic alkalosis, all your potassium will go intracellular. If you give fluids and remove the contraction alkalosis, then potassium will stop going inside and it will increase in your, it will actually come back outside. That's why you should give fluids. How do you approach hypokalemia at the bedside? A lot of what I am telling you isn't available in textbooks. So when I will tell you what the approach you need to copy, you can do that. Most patients will be asymptomatic, and the important thing to know is hypokalemia will never manifest neurologically. So if a patient is drowsy, it cannot be because of hypokalemia. He is having convulsion, can never be hypokalemia. Hypokalemia will only cause conduction abnormalities, so you will have arrhythmias, you will have paralytic ileus, you can have quadriparesis due to skeletal muscle weakness, never neurological. There are various causes of hypokalemia. People use this in the exam. What we are interested in the bedside, in my patient, what is the cause? Now, here you need to follow a specific approach. First, hypokalemia can be life-threatening. If there is a ventricular tachycardia, that's not the time you want to do calculation to find the cause. Treat that. If patient is not breathing because of muscle weakness, put on the ventilator. Get him safe first and then try to look at the cause. And think, can this be spurious? Patient is too good. You and me walking around. If you get hypokalemia, that cannot be the cause. Now, the second thing is potassium. Two things happen to potassium. It can either go inside the cell or it can be lost from the body. How can you differentiate whether potassium is lost from the body and causing hypokalemia or it has just gone into the cell? Anyone? Because this is one of our contribution to critical care. It's not in the textbooks how to differentiate it, but the answer is very simple. Anyone? How can you tell whether the potassium is lost from the body, in which case you have to replace it, or it has just gone into the cell, you have to reverse the process? Anyone? The answer really is not ABG, really nothing else. It's how fast it occurred. To lose potassium, say I tell you, you may say, if I give you 100 crore rupees and ask you to spend it in 2 hours, trust me, you will not be able to do it. You may say, what is the problem? Because when I give it to you, you will say, should I buy a BMW? Should I buy a Skoda? You cannot spend it in 2 hours. Kirtilal Mehta, who is the owner of Lilavati Hospital, 15 years back, he featured in the Lifestyle of Rich and Famous because on his birthday, in 4 hours, he spent 4 crore rupees. So he was projected all over the world. You and I can't spend it. Okay? So if potassium is to be lost from the body, what happens? If you lose potassium in the urine, intracellular potassium will come out and it will still be corrected. You lose more, intracellular will still come out. So by the time you manifest hypokalemia, it will take many days. Have you understood? It's like you are not earning, your father is keeping depositing in your bank. And if your bank doesn't have balance, then now your father is also poor. That's what it means. Intracellular is also poor. But if I have to shift it inside, it's like depositing in the bank. I can write one check and transfer online 4 crores from this bank to that bank, intracellular to extracellular. So if it occurs in minutes or hours, it's a transcellular shift. If it occurs over days, it's actually lost from the body. Have you understood this? Very important to approach hypokalemia. Usually, hypokalemia is due to only 3 reasons: vomiting, diarrhea, diuretic. And that is clinically evident to you. But if it's not evident and you're clueless, then you have to follow an algorithm which I will show you. And the important thing to know here is 2 things. How is the kidney behaving? And is this person got blood pressure or not? Why? How is the kidney behaving? I got hypokalemia. My urinary potassium is low, which means the cause of potassium loss is extrarenal. The poor kidney is trying to conserve potassium and therefore you're not losing it in the urine. Whereas you have hypokalemia and your urinary potassium is high, that means the culprit is the kidney. It is losing all the potassium from your body. So to differentiate renal from extrarenal cause, do urinary potassium. Okay, that's one thing you must understand. Second is this patient got hypertension or not? Because an important cause is mineralocorticoid excess, in which case patient will have hypertension. Now, 3 possibilities. If patient has hypokalemia, it could be spurious, right? And when you say spurious, you mean drip arm sample. Or it could be redistribution or transcellular shift, in which causes are very limited. Insulin causes potassium to go inside the cell. Salbutamol, nebulization, they cause potassium to go inside. Metabolic alkalosis does, refeeding does. And if you exclude this, then you're left with hypokalemic periodic paralysis. Alright? So you diagnose hypokalemic periodic paralysis only if you've excluded the patient is on drugs and there is no metabolic alkalosis. Now, though that is easy to make out, if it's a true loss, then you must find out where the loss is, renal or extrarenal. And so you do the urinary potassium, spot potassium, and estimate the urinary loss per day, not per liter. Less than 20 means it is extrarenal, more than 30 is renal. If it's extrarenal, the cause is usually obvious, vomiting, diarrhea, diuretic. And if it's not obvious, like it could be surreptitious vomiting, diuretic, someone is taking just to lose weight, or laxative abuse, then what you do is do a blood gas. Metabolic acidosis means it's the lower GI loss. Metabolic alkalosis is vomiting or diuretics. Okay? Now, if it's a renal cause of potassium loss, then you must always do a blood gas. To find out if it's metabolic acidosis, alkalosis, metabolic alkalosis is the commonest, but if you see metabolic acidosis with hypokalemia, there are only 6 reasons. Renal tubular acidosis, diabetic ketoacidosis, sometimes in bad managed case, amphotericin, adrenaline, ureteroenterostomy, etc. So these are pretty much predictable. Renal tubular acidosis type 1, type 2, DKA with potassium depleted state, drugs like adrenaline, amphotericin and Dimox, and ureteroenterostomy. It becomes very easy to diagnose if you've got metabolic acidosis and patient is losing potassium. Variable is hypomagnesemia, and if the patient is on penicillin group of antibiotics which are used very often, they can cause hypokalemia. You must know that. Now, if the patient has metabolic alkalosis, this is when you want to rule out mineralocorticoid excess. So you say, is the patient having blood pressure or not? If the patient is not having blood pressure, then it's possible the person is on diuretics for some other reason, congestive heart failure, or a condition called Bartter syndrome, which is just, you know what Bartter syndrome is? It's a congenital defect in which, or an inherited defect in which the same receptor where furosemide acts, sodium potassium 2 chloride receptor, that is abnormal. So it's as if the child is on continuous Lasix infusion. That is Bartter syndrome. Most of them die before they're 12 years of age. If the person has hypertension, then there are 2 possibilities. Either he is an essential hypertension who is on diuretics because it is recommended treatment, or he's got mineralocorticoid excess. How will you differentiate the 2? Here, urea creatinine ratio will be high, hypovolemia. Here, euvolemic state. So urea creatinine will be normal, mineralocorticoid excess. And when you have mineralocorticoid excess, you need to do renin and aldosterone levels. If only aldosterone is high, it's primary hyperaldosteronism. That means it's an adrenal problem, adrenal adenoma, adrenal hyperplasia, adrenal malignancy, etc. If aldosterone is high and renin is also high, secondary hyperaldosteronism. That means if it's a renin secreting tumor or renal vascular, renal artery stenosis, coarctation of aorta, and if both are low, then Cushing's. A few months back, we were in Bangalore. We were taking this lecture. There was a pediatrician in the audience, and she said, "Sir, I have a patient with hypokalemia. Urinary potassium was around 50 millicurrents per day. We did the renin aldosterone level. The renin was high, aldosterone was high. We thought of renal artery stenosis. We did ultrasound. There is no renal artery stenosis." In the audience, she didn't see the slide. And I said, "Madam, your child has got coarctation of aorta." I said, "How? You've not even seen the child. We've done everything, workup." I said, "Anyways, you can understand that if it's renal vascular, renal artery stenosis, coarctation are the only 2 possibilities." She had ruled out renal artery stenosis. So, like a big magician, I said, "Your patient has coarctation of aorta." 1 week later, she says, "Sir, MRI shows coarctation of aorta." And it was all started with the story of hypokalemia. Urinary potassium was high, metabolic alkalosis was there in that case, renin, aldosterone. They had already done everything. And so you can make out very good diagnosis if you follow this algorithmic approach. The second question is, how much potassium should you put into a pint? Because I hope you're now convinced that the treatment of dehydration is more important than potassium, don't put too much potassium into the bottle. And if you have a rule, not more than 1 ampule in a pint. When the potassium falls from 4 to 3, how much is the deficiency in the body? 400 to 600 milliequivalents. Right? You won't correct by more than say 120 milliequivalents in a day, which means how many ampules? How many ampules of potassium will you give? 1 ampule is 10 ml, 20 milliequivalents, 6 ampules, right? To give 6 ampules, if you put 3 in 1 pint, you won't give fluids. If you put 1 in a pint, how much pints you have to give? So 3 liters will go, na? That will correct your hypokalemia, not your potassium. So make it a rule, don't give too much potassium, give little potassium with each pint. You will be forced subconsciously to give more fluids and it will get corrected. So that is the logic of don't give more than 40 milliequivalents per liter, which is 20 milliequivalents in a pint. Always consider the possibility of hypomagnesemia. There is no such thing as serum magnesium being normal, it cannot be there. 80% of patients with hypomagnesemia have normal serum magnesium. It is useless to even do magnesium levels. Okay? We have done enough studies to show that patients in the ICU are magnesium depleted. How do you do that? If you want to really know, do a magnesium challenge. If you give 4 grams of magnesium in a pint over 1 hour, right? If there is no magnesium deficiency, the body will throw 80% of it out in the urine, so it will recover that. So give magnesium in 1 hour, collect the urine for next 24 hours and see how much magnesium is there. If only 50% is excreted, 50% is retained, it confirms magnesium deficiency. In most of our patients in the ICU, when we gave 4 grams, we did not even recover 0.1 gram. We should have 2 grams if we recovered was good, 0.1. And therefore, it's a very, and most of them had normal serum magnesium. This is the way to prove magnesium deficiency. But you must empirically think of it. If there is malnutrition, alcoholism, patient is diabetic, he's on chronic, has got chronic diarrhea, chronic diuretic use, he's on aminoglycosides, he's got torsade on ECG, he's got hypokalemia which is not responding to treatment. Or if he has got hypokalemia and also hypocalcemia, just close your eyes and say this patient has hypomagnesemia, because the metabolic pathway, the common factor is magnesium. Okay? So you've understood that these are very important things to in your management of hypokalemia. Now, just let's go by our approach. This lady has episodes which last for few hours or days. In few hours it comes and goes. Is it transcellular shift or true loss? Transcellular shift. Okay? If it's a transcellular shift, she's not on insulin, not on beta agonist, there is no metabolic alkalosis, therefore you diagnose hypokalemic periodic paralysis in this patient. Incidentally, the heart rate of 124 is odd. That means this is thyrotoxic type of hypokalemic periodic paralysis, and these patients respond to beta blockers. Now this lady has weakness over few days. So this is not a transcellular shift, this is a true loss. It's a true loss. How much is the potassium loss? 11 milliequivalents per liter, 3.5 liters, so more than 30. The kidneys are the source of losing it. Then you look at metabolic acidosis or alkalosis. There is metabolic acidosis. So you saw that list: RTA type 1, type 2, DK, adrenaline, amphotericin, Diamox. This is not on adrenaline, amphotericin or Diamox. She does not have, the blood sugar is not here, sugar was not high. So straight away you diagnose RTA type 1 or type 2 in this patient. Have you understood how you approach at the bedside? Same way, hypertensive patient, metabolic alkalosis, you diagnose. Now, just like I told you with metabolic acidosis, for every 0.1 drop in pH, your potassium is falsely elevated by 0.7. In alkalosis, for every 0.1 increase in pH, potassium drops by 0.3. So how much is the potassium changed by from 7.4, which is normal pH, to 7.7 is 3 times. 3 into 0.3 is about 0.9. Just correcting the alkalosis, your potassium will increase by 0.9 and become 2.9. These are important if you are in the ICU when you are doing day-to-day care. You need to know what is the corrected potassium. What seems like the end of a lecture is really just the beginning of learning. So I hope you've understood some of the things about potassium. Most importantly, it's not the potassium but the volume correction which is important. You should not put too much potassium into a pint, and that's about it. And then you need to correct potassium. there is no such thing as a lab reporting a serious patient and you trust the potassium because pH will be abnormal. You need to correct for pH and find out what is happening. Okay. The organizers have given me, they told me to torture you, give me a lot of topics. I don't know how much you're comfortable with. Anytime you want to end it, we can. The audience respond. There's some error in your projector.
Which you should use for giving potassium?
Half saline. 0.45 saline. Okay? Because when you're giving it, see, potassium is only lost when you lose fluids. Vomiting, diarrhea, diuretic, etc. When you lose fluid, it is never serum that you lose. You lose predominantly water with some electrolytes. So there is intracellular dehydration always. If you use normal saline, then you're further going to cause intracellular dehydration. So you must always put it in half saline. People may say, sir, in our hospital it's not there. If you don't ask for it, it won't be there.
Sir, if the patient is having both hyponatremia and hypokalemia,
Then you can use saline. It's not a problem. Then you can use saline.
Sir, a patient of hyponatremia, he has got altered consciousness and cerebral edema.
Now, altered consciousness, patient has got
Hyponatremia, he has got altered consciousness and sometimes these patients have got cerebral edema. So that's the
okay.
mannitol and mannitol can be used mannitol and disease.
Why he's got cerebral edema, I'll tell you. He probably have had hypernatremia. Okay, let me take my lecture on hypernatremia, you will understand the cause. Okay? Wow, projector, someone has to. You have some error in your projector again. Is it too difficult? Am I going too fast? Shall I slow down? Because it's important that you benefit from it. It's not important to cover all the topics. We can skip ABC if required. We can switch over whatever you want. Slightly slow? Alright. As I always say, in a meeting like this, I'm acutely aware that your time is very important. And I always feel like I'm the girl's father and you're the boy's father and I have to look after you. I have to satisfy your needs. It's not important. So you tell me what you want. You want me to go slow, I will. हम लड़की वाले हैं, आप लड़के वाले हो. तो आप बताओ, नहीं सर ये टॉपिक चेंज करो, ये डिफिकल्ट करो, ये बहुत आसान करो. I will do that. Alright? Because I have come here for you. Okay, let me take my hypernatremia even without the slide. Hypernatremia is the simplest problem. It just means there is less water in the body. Your question, your role in hypernatremia is finding out where the water is lost. Renal or extrarenal. Extrarenal is very simple. Vomiting, insensible loss, okay, heat stroke, etc. How do you make out if it is renal or extrarenal? If it is renal loss, he will be having polyuria. So, if he is having more than 3 liters of urine per day and having hypernatremia, it's a renal cause. Simple. There are only 2 things you must do. If it's a polyuria, do the urine specific gravity or urine osmolarity. If it is due to diabetes insipidus, it will be very dilute urine. Osmolarity will be low. And if it is due to osmotic diuresis, like diabetic ketoacidosis or mannitol, it will be high osmolarity in the urine. Simple. So if it is low, and we are really concerned with diabetes insipidus, that if you have low urine osmolarity, low urine specific gravity, you know it's diabetes insipidus. Is it central or renal, nephrogenic? Give ADH or vasopressin. If it gets corrected, it's central. If it doesn't get corrected, it is nephrogenic diabetes insipidus. I have already finished my lecture. So we will run through the slides. Actually, it's easier to take without slides, but you won't enjoy it. We'll just run through it and maybe do some cases. A 34-year-old psychiatric patient is producing 6 liters. Now it will all become simple.
Yes.
Now you will all So let Yavatmal give me 100% results. Okay. Producing 6 liters of urine per day, urine osmolarity is 75. What is the next appropriate step in this patient? So a patient comes to you saying is producing a lot of urine, urine osmolarity is low. Will you do water deprivation test? Will you measure serum electrolyte? Will you measure urine electrolyte? You send for urine routine examination for urinary tract infection.